Hello, I'm Jim Smirniotopoulos, and we're going to talk now about von Hippel-Lindau disease or syndrome. This is characterized by multiple hemangioblastomas, visceral cysts and cancer, pheochromocytoma, and neuroendocrine cancers. The live birth incidence of VHL is about 1 in 36,000. There's no racial or gender predilection. It's an autosomal dominant disorder caused by a mutation on chromosome 3 that causes a missense or truncation disruption of folding the VHL protein, which is involved in the degradation of hypoxia-inducible factor. We like to think about von Hippel-Lindau disease as having the rule of threes. It's on chromosome 3p. VHL has 3 letters. The most important and common manifestation are central nervous system hemangioblastomas, which is also 3 letters. The patients are prone to develop renal cell carcinoma. Hypoxia-inducible factor is the molecular biology failure in these patients. They also develop multiple endocrine neoplasia syndromes, or MEN, and the special stain for renal cell carcinoma is epithelial membrane antigen, or EMA. One pearl to keep in mind is that von Hippel-Lindau disease has no prominent cutaneous findings, another situation where the medical dictionary definition of Phakomatoses is incorrect. The manifestations of von Hippel-Lindau disease extend way beyond the central nervous system. Approximately 100% of the patients will have hemangioblastomas, most of which are in the brain. They also have retinal angiomas, which in reality are histologically hemangioblastomas. They develop endolymphatic sac tumors, renal cysts, renal cell carcinoma, significant risk of developing these cancers in patients over the age of 60. Pheochromocytoma characterizes a subtype of VHL. Pancreatic cysts, pancreatic neuroendocrine tumors, and epididymal and broad ligament cystadenomas. The clinical diagnosis of von Hippel-Lindau disease can be based on the presence of brain and retinal hemangioblastomas, a hemangioblastoma, and one of the important visceral findings, or a family history of von Hippel-Lindau disease, and one of these important features: hemangioblastoma, visceral lesions, pheochromocytoma, or renal cell carcinoma. There are several subtypes of VHL. The most common is type 1, which does not have pheochromocytoma. Type 2 patients have pheochromocytoma, and they may have additional neuroendocrine tumors. We want to remember that VHL is one of the many multiple endocrine neoplasia syndromes. There are 6 classic lesions that we can see on imaging in patients that have VHL. Hemangioblastomas of the retina and the cerebellum, renal cysts and clear cell renal cell carcinoma, pancreatic lesions, pheochromocytoma, and the cystadenomas of the posterior fossa, the epididymis, or the round ligament. The retinal angioma is typically seen as a red spot on the fundus. It is going to cause a blind spot for the patient, but is otherwise relatively innocuous. We can also see these on fluorescein angiograms, which are typically done by the ophthalmologist. They may have 1 or 2 dominant feeding arteries, but they typically have slow flow, so they don't show early draining veins. A classic example of hemangioblastoma here, a lesion in the posterior fossa that is biphasic. It has a fluid component. It has a nodular component. The nodule shows contrast enhancement. Oftentimes the rim surrounding the fluid does not contain neoplastic tissue and therefore does not show any contrast enhancement. Hemangioblastomas are true neoplasms. They're not vascular malformations. They are now considered to actually arise from hemangioblasts, primitive vascular stem cells, And again, even though they are hypervascular, the vascularity is primarily composed of capillary and sinusoidal channels, and they have relatively slow flow. In between the vascular spaces are these foamy, lipid-laden stromal cells. The classic hemangioblastoma, again, is going to be seen as a partially fluid, partially solid lesion in the posterior fossa. We may also be able to see that there are flow voids related to the nodule or sinusoidal flow voids within the nodule. It is another WHO grade 1 tumor. The peak in clinical presentation is typically around 30 to 35 years of age. Hemangioblastomas have a hypervascular nodule. We can see that there is displacement of the normal vessels by the invisible fluid portion of the tumor, a single dominant feeding artery. And then we can also see in the venous phase that there is a prominent vein draining the mural nodule. The mural nodule blushes because of the contrast within the capillaries and the sinusoids. So again, we see on angiography the same morphology that mimics the appearance on cross-sectional imaging. If we do perfusion imaging in hemangioblastomas, we will see that the nodule is hypervascular and has increased perfusion. This is in contradistinction to the cyst and mural nodule appearance of the pilocytic astrocytoma. In pilocytic astrocytomas, the nodule will not show increased perfusion. If we look here at the histology of the hemangioblastoma, we can see that there is a cavity or fluid-filled space. There is a mural nodule, and typically the mural nodule is located in a peripheral, superficial, or subpeel location. We can also see that there is a thrombosis in one of the larger sinusoidal vascular spaces. This is the histology of the hemangioblastoma. We can see the clear, lipid-laden, foamy stromal cells, and in between the stromal cells we have all of these vascular spaces, which in this particular case are capillary in size. So again, we have the hemangioblastoma presenting as a biphasic lesion. It's important to remember that because there is protein in the cyst fluid, it will not be isointense to CSF on the T1, T2 weighted image, and it will be especially different on the FLAIR images. The hemangioblastomas can be multiple. They're primarily going to be infratentorial, involving the retina, involving the spinal cord. They can also occur in the nerve roots. There are certain areas where there is a higher incidence of the VHL mutation, and these include Hawaii, Puerto Rico, and Newfoundland. We can also see endolymphatic sac tumors in patients who have von Hippel-Lindau disease. These have the histology of a cystadenoma, which is very similar to the histology that is seen in the round ligament and in the epididymis of the testis in patients who have VHL.